It's a real pleasure to be able to participate in today's Taylor Symposium, and a particular honor to be able to be part of the celebration and recognition of Dr. Youssef's award, his tremendous contributions to cardiovascular research, and indeed his amazing contributions to the health of individuals around the world. It is truly an honor. As Murray said, I will discuss aspects of this notion of aging of the vasculature. Normally the more basic science talk comes first before people have rolled in with their coffees. So now that I'm actually at the end of the morning session, it's a little bit unsettling, but I think we can work our way through. And I'm going to begin just by showing this schematic that I've created for the aging trajectory. You can see a standard age on the x-axis, and here's my quantitative y-axis. And I guess this is pretty well what something like we might all want to undertake. Perhaps this is what J. Allyn Taylor himself did in terms of just living your life fully, feeling great until those final few moments at a ripe age. But of course, this is much more common to what we would see, particularly in individuals with cardiovascular disease. We try and therapeutically change this trajectory if it is all possible. If we're able to shift the curve in that direction, we've expanded an individual's lifespan. But equally, perhaps more important, is if we can shift the curve up in that direction. And the terminology for that these days tends to be improving an individual's health span, and putting them both together, and that's a very reasonable and exciting goal. Now, we also know, and it's been in fact known for centuries, that one of the primary determinants of where you fall on this particular trajectory is the extent to which the vessel wall in an individual is healthy and robust and can withstand the stresses imposed on it over the course of that individual's lifespan. And as I say, this has been recognized for centuries. Here is what William Osler had to say about it when he was contemplating it in 1891. Longevity is a vascular question, which has been well expressed in the axiom that a man is only as old as his arteries. To a majority of men, death comes primarily or secondarily through this portal. The onset of what may be called physiological arteriosclerosis depends in the first place on the quality of the arterial tissue which the individual has inherited, and secondarily on the amount and wear and tear to which he has subjected it. So I think when we every time I read that quote, I'm struck by the fact of how perceptive it seemed at the time. It captures many of the things we've been hearing about this morning, and really everything holds true today. But I suppose the flip side of that is, well, if everything holds true today, and Ulster had this kind of sorted out 120 years ago, to what extent have we really advanced in our thinking with respect to the notion of aging and vascular disease? Is it just accumulation of risk factors, things wear apart and you go downhill? Or in fact, are we able to dissect this a little bit more and begin to address it that might in fact help individuals enhance their health span? And I would say, so that's the question, has our understanding of vascular aging, certainly vascular disease we understand a lot more, but the notion of aging per se, has our understanding increased to any extent over the last 100 years? And I would say, yes, it has begun to, and it started to do that in a specific year, 1983. And that's because of a finding in a worm. Bit far off from the vasculature, but in fact in 1983, that was I would think, it could be considered as the launch of the modern era of aging research, because that was the first identification of any species in which a genetic mutation was identified that rendered increased lifespan, and it happened to be in C. elegans, a worm. And that sort of launched a whole new era in trying to understand what aging was, because we could now identify various cascades, molecular cascades, whether they were metabolic or survival-based, but all sorts of chipping away at this specifics of what aging really is has taken place in the last few decades. Now, so then the question becomes, does that shed any new lights on vascular aging in people? And so I'll try and address that in these three topics. The first being looking at aging events as they can be quantified in circulating cells. The second, aging in large arteries. And the third, aging and regeneration of small arteries. So with respect to thinking about circulating cells, here's the trivia question. Do you remember what the name of these plastic doodads is on the end of shoelaces? So, aglets. Remember, it's a Trivial Pursuit question. Most people never get it. So, but you know, they play an important role, because if the aglets wear off on your shoelace, it becomes unraveled, and this is not a good scene. It's just not good for sensible footwear. And it turns out that our chromosomes have aglets. We don't call them aglets, we call them telomeres. But that, in fact, is a very, I think, noteworthy parallel. They serve to protect. It's a repetitive DNA sequence and associated protective proteins that effectively protect the ends of our chromosomes and prevent the body from thinking of them as broken pieces of DNA, so that it inappropriately starts gluing two chromosomes together. And one of the fundamental biological pieces about chromosome biology is that they shorten in length, the telomeres do, every time the cell undergoes a replication. And this is just illustrated here schematically. And this has a few consequences. One, if a cell shortens enough and the telomere gets dug into enough, then this is the problem. And now the cell says, I don't have the protection, and it just becomes senescent, stops performing in a functional way, doesn't necessarily disappear or die, but it just sort of sits there as a non-functional cell, has a pro-inflammatory attributes, and is effectively a problem. And that's one notion about how aging in people might take place. You accumulate senescent cells. The other important implication, however, is that if you can track the length of telomeres, then you are effectively chronicling the replicative history of a cell, which may in fact be a biological readout for aging over and above an individual's chronological age. And this particular perspective on telomere biology has been picked up with a translational perspective, essentially trying to address phenotyping of individuals with that in mind. And really this is the logic that's currently being considered. In order to detect differences in the length of telomeres in an individual, there really needs to, or either over time or between cohorts or cross-sectional analysis, there needs to be really an awful lot of proliferation that has taken place. A lot of cells have to undergo a number of cycles of cell division before you can actually pick up the fact that the telomeres have been shortened. And this, by and large, is going to be a stem cell generated process, because the stem cells are going to give off their daughter cells and they're going to amplify in an exponential fashion, and now we've got some serious proliferation going on. And where's that going to happen? Well, that's going to be primarily, we think, in the bone marrow. So the sense would be that the peripheral leukocytes will in fact reflect what's going on from a proliferation standpoint in the bone marrow. And if you can measure the length of the peripheral leukocyte, it's easy to access. Then now you have a window on the proliferative activity in the bone marrow. Proliferative activity in the bone marrow, in turn, is going to vary from person to person, in large part depending on the extent to which they are subjected to inflammatory stresses. So individuals that are subjected to repeated inflammatory bursts over the course of their lifespan are going to have more hyperactive marrow response, or chronic inflammatory disease, which is, of course, what vascular atherosclerotic disease is all about, will likely be, in fact, have an impact on the bone marrow. And this is borne out in a number of trials. These are generally fairly large trials, let's say more than 1,000 patients, where in cross-sectional analysis, it's been identified that low or shorter telomeres in circulating leukocytes is associated with really most, if not all, of the cardiovascular risk factors that we recognize. And in at least one trial, the West of Scotland trial, it identified a cohort of patients that was at somewhat higher risk to develop coronary artery disease. So we, in collaboration with our partners in the cardiac surgery department, have evaluated the length of circulating telomeres in individuals undergoing cardiac bypass surgery or other forms of cardiac surgery that don't require bypass. And I'll just show you one or a few pieces of data here. Here we're looking at the relationship between the leukocyte telomere length and simply the age of the patient. Now, about 70 of these patients, this is the first 98, 70 of them, as I say, had bypass. They've got advanced atherosclerotic. The other 28 had cardiac surgery for non-coronary reasons, but for the data at this point, they're not different, so I've just pooled them to show this. And you can see there is an inverse and linear correlation between the length of the telomere in the circulating leukocyte and the patient's age. This is not especially surprising. This type of pattern has been found in most other cohorts in which it was tested, usually requiring many more patients than this, so we were satisfied that we were able to at least detect the fact that telomere shortening can occur, and we can identify it in this population, in their leukocytes. But where we took it to a slightly more unique level is not only did we measure the length of the telomere leukocytes, length of the telomeres in leukocytes, we also measured it in selected tissues from the same patients. And here, the notion of telomere biology in our solid tissues is much murkier. We don't really know what's going on. But we specifically focused on tissues that we felt were not especially replicative and rich in muscle cells. So that's some cardiac muscle, some vascular muscle, and skeletal muscle. And interestingly, the telomere lengths are really quite different. They're much longer in each of these tissues, which perhaps, again, is not entirely surprising if we're thinking this is reflecting a major replicative source. And these, by and large, particularly when you dissect out the muscle component of the vasculature and of the heart, they're considered to be non-mitotic, end of stage in terms of differentiation tissues. So I guess it does make some sense. We didn't find any differences between sex. What was interesting, though, was that then when we evaluated this relationship between the age of the patient and the length of the telomere in a given tissue, that now the situation became more nuanced. Our anticipation was that these would be straight line. There wouldn't be any decline in telomere length over time. It's non-mitotic tissues, but that wasn't the case, at least in all tissues. So here, for example, in skeletal muscle, lo and behold, your telomeres shorten. Perhaps not as quickly as they do in your leukocytes, but still, it only took 98 patients to detect the fact that they're shortening. So this is, in fact, a much more active, probably stem cell-based tissue. These are healthy skeletal muscles. There's nothing diseased in these individuals' skeletal muscle. There's no myopathic process, and yet it's shortening. So the tissues are more, at least some are more alive and remodeling than we have, I think, otherwise thought. However, this wasn't the case for the media, the muscle layer of the vessel wall, at least for the two vessels we looked at, the saphenous vein and the internal thoracic artery. We know that the internal thoracic artery is a fairly stable vessel, and perhaps that's not surprising, but veins, they're subjected to abnormalities. And again, we're looking over the course of 50 years, and at least in terms of the numbers of individuals we looked at so far, these were very stable. So tissues are not the same throughout the body. And so we'd simply have a few implications at this point. One is that you saw the spread. I mean, the inter-individual variability in the length of a telomere, among the is high. And so at this point, I would say that as an individualized predictor of cardiovascular events, a single telomere length assessment in your leukocytes or in your tissues is not going to be tremendously informative. So at this point, I would not send your blood down to one of these telomere length companies to get the information, because you really won't know what it means. Secondly, that it's interesting that there's more we need to understand about how our tissues turn over, because the bone marrow is in fact not the only tissue where this lifelong cell turnover takes place. Healthy skeletal muscle must have a much bigger and active dynamic stem cell pool than we thought. But the question was, how do we interpret this business of the telomere shortening not in fact occurring in vessel walls, even over this fairly long 50 to 60 year time frame? And I think there's a couple of interpretations. We might say, well, that's good, because there's no evidence for aging in these tissues. But I think that's not correct. And really a more accurate statement would be there's no evidence for ongoing accumulation of replication in these tissues. And we know that vascular tissues age. That's the whole point here. So in fact, I think it's not good at all. It's really bad. The fact is that there is no evidence now for the existence of any substantive stem or progenitor cell-based regenerative program in our vessel walls, in the muscle layers, that in fact would combat the forces of aging. And this in fact may well be at least one reason why the vascular aging process is perhaps faster than that of other tissues. So with that in mind, I just wanted to discuss what exactly is going on in the vessel wall from an aging perspective. And as I noted, I'll try and do this by looking at both large scenarios of large arteries and scenarios of small arteries. Thinking about large arteries, this is a fundamental, I've got two tenets that are very fundamental with vascular aging, and for large arteries, it's that they get stiff. Again, recognized for centuries. And I'll just touch on this notion of large artery disease and their stiffness here. So this is a standard H&E stain of a human aorta. It has a classic layered appearance with the elastin lamellae, and in between is the row of vascular smooth muscle cells that make the elastin give the tone to the artery. Now, neither the muscle cells nor the elastin are what cause vessel walls to get stiff. What causes them to get stiff is the collagen, which we don't see in a standard H&E stain, and it's often underestimated at the best of times. We look at it a few different ways, but here's one very sensitive way to identify the collagen fibrils in the artery wall. It's making use of the fact that collagen fibers are birefringent, so if you shine polarized light at them, they light up, everything else is black. And you can appreciate that, on either side of the elastin lamellae, which is now black, you've got much more collagen than one might otherwise have expected, and it's effectively sandwiching the vascular smooth muscle cells. So it's the smooth muscle cells that make the collagen, and it's also smooth muscle cells that degrade the collagen. And there's in fact a balance that would go on like we expect in most tissues. But it's this degradation that I think is most interesting when we're thinking about it in terms of the concepts of vascular aging, because it's been recognized for over 50 years that the extent to which an individual's collagen can be degraded, in fact, is a major determinant, or rather age is a major determinant of this degradability. In other words, it becomes resistant. Our fibers, they're cross-linked. Diabetics, they become glycated, just as aging, cross-linking between collagen molecules and between fibrils just makes them stiff. And we get stiff as we age. That's a primary reason. Our collagen fibers are becoming stiff and unmalleable. And so here's just this report in 1972 where, in fact, it's been argued that you can actually determine the chronological age of an individual just by seeing how digestible a piece of skin is. Now, obviously, that's a rather roundabout way of finding out how old someone is. You could just ask them. But nonetheless, the relationship, in fact, holds true. It's very strong. And we were curious, is this simply is this degradability of collagen simply a biomarker of aging, or in fact, does it have some causative role? So to address that, we have moved down from humans to the mouse and asked the question, what are the consequences of degradation-resistant collagen on the vessel wall during aging? And that could be answered because of a mutation in this collagen molecule that's been made. So here's triple helical type 1 collagen. In order to degrade it, you need to make a cut 3/4 along the length of the molecule. Without that cut, it doesn't get degraded, or at least very, very slowly. Because it's an identifiable cut site, that can be mutated, which is what's been done, so that it renders it resistant to cleavage by these particular matrix metalloproteinases. Now, this particular mouse, you would have thought might die early on. It doesn't, because it turned out there's another site farther up the molecule that turns over more slowly. But that was very beneficial for us, because now we could embark on really investigating what happens over time in this mouse that has this resistant, degradation-resistant collagen. The mice actually looked like they aged pretty quick. They started getting craggy after about 7-8 months. They got much more hunched in the back, and that's just shown here. These are CT surface renderings of the bone that we've undertaken in collaboration with David Holsworth. Mice, of course, always look pretty kyphotic when you look at their spine. Well, not of course, you may not think about what mice's spine look like, but here it is. And much more hunched in the mouse that has this mutation, and indeed with these Kaplan-Meier curves demonstrating that their survival is impaired as well. So it was evidence for global accelerated aging. What about at the vascular level? Turns out there was a lot more collagen. This is now black and white, but the same birefringence type of image. A lot more collagen is accumulating in their aortas, which in itself was interesting because, again, that must imply that there's a lot of editing, there's a lot of degradation of collagen that goes on just over time. It's not just you lay it down, after the vessel has developed in the early few years, and then it stays there. So clearly, it's always being chopped up a little bit. And consistent, there's some quantitative data, and consistent with that, the blood pressure in the mice is up, their pulse pressure is up. The arteries, in fact, are stiffer, as shown on this length tension curve. More interestingly, we thought, from the standpoint of aging, is when we evaluated the consequences of this extracellular matrix mutation on the cells themselves, specifically trying to determine whether, in fact, there were any features of accelerating aging in the smooth muscle cells. Were they, in fact, being driven down a senescence pathway? One way one does this in culture is you stain for what's referred to as senescence-associated beta-galactosidase, which is essentially an indicator of the fact that cells that are becoming really old and senescent rapidly accumulate their lysosome content, and then they turn blue. We adapted that to study that in this in vivo scenario, and were surprised to find patches of extensive senescent smooth muscle cells. Wasn't everywhere, and in fact, it looked like there was a very distinct hotspot in the ascending section of the arch of the aorta. And other biomarkers of senescence were concordant with that, as shown here with this cell cycle inhibitor. So this, we thought, raised a couple of intriguing points. And one is, as I've titled here, it looks like aging begets aging. So this chronic aging that takes place in all of our collagenous tissues over time just doesn't stay in the extracellular matrix. It crosses over and somehow impacts the life cycle of the nearby cells. What the implications are of that for, I don't know, except maybe we should keep our skin in great shape, or at least think perhaps more about mechanisms of maintaining our collagen fibers malleable. The other implication, or the other note, was that this business of it happening particularly in the ascending aorta. Of course, we know that there are many conditions where the thoracic aorta becomes diseased. In atherosclerosis, yes, but also in a number of non-atherosclerotic conditions where the aorta in the thorax is dilated, it's vulnerable to becoming dissected, which leads to catastrophic consequences. And that's not just in, elderly, that can be in individuals with, at middle age, and strikes them down, in the prime of their lives. So it made us wonder, is in fact the proximal aorta a hotspot to dysfunctional or unhealthy aging in humans now? Trying to bounce back from the mouse level to individuals. One population that we thought might be a valuable one in which to address this was those individuals that have a bicuspid aortic valve. So this is just an ultrasound view. Most individuals will have 3 cusps for their aortic valve here. This individual only has 2. 1% to 2% of the population have a bicuspid aortic valve. But it's not just their valve that is vulnerable, it's also the ascending aorta that's beyond that, shown here. This would be normally the diameter of the root in the ascending aorta. In this particular individual, it's the same image. It's an image from the same individual I just showed. It's much more dilated, and this is prone to dissect and cause, as I say, catastrophic complications. Over the course of 10 years, there's about a 40% chance of a serious problem in this regard. Why these aortas dilate, we're uncertain. It may be hemodynamic, there may be genetic influences, embryologic basis is fairly suggestive, but regardless, what takes place in that vessel wall when they're subjected to whatever hemodynamic perturbations that are going on is unknown in large part. And I'll just show 2 pieces of evidence, or 2 slides, to address the conclusion that we're heading towards now, or feel that we've arrived at, in fact, is that this is a zone of our vasculature that is predisposed to accelerated aging. And so here's, again, that senescence-associated beta-galactosidase activity. This, it's just one blue stain, one little blue cell in the artery wall, but we think it's a big deal. This is a cell, by virtue of staining, that has, in fact, gone to seed. It's not functioning anymore. Hao Yin and Zhengzhuan Nong make this assessment. It has to be done on freshly harvested tissue as soon as it comes out of the patient. It takes all night long while they're sectioning and staining it, but I think this is a major finding in of itself, and we're finding that not across the board, but in a number, and there's confirmatory evidence by immunostaining for other markers. The other aspect of an aging cell that we were particularly interested in was the extent to which the DNA in the cell is remaining in a decent shape. I mean, genomic integrity does fall off as we age, and one fairly extreme form of that is when both strands of the DNA are cut, double-strand DNA cut, which is normally fixed very quickly, except in tumor cells or in individuals with genetic defects that don't repair DNA. And so we're curious, do you think we could actually find this in these premature aging zones? And you can do that by immunostaining for a modified form of a histone, as shown here. And remarkably, look at these individual dots showing a foci of DNA damage within the nucleus of a vascular smooth muscle cell in a patient with a bicuspid aortic valve. And in fact, this was not uncommon. Brittany Balint in the lab has been quantifying this scrupulously and has now identified that up to 30% of the cells within the vessel wall of aortopathy patients have unrepaired DNA damage. Control patients of those aortas that have been excised for reasons other than aortic disease, it's 0. Marfan's, a striking aortic abnormality, is even more compelling. Now the foci are bigger and more plentiful. And this is interesting because this, of course, is another matrix abnormality. That's the genetic mutation housed in the fibrillin gene is out here in the extracellular matrix. Again, giving this notion that things going awry in one compartment are, in fact, badly impacting the cell, and down an aging path they go. So finally, just in the last section, I'll discuss some aspects moving from the big vessel right down to the microvascular tree. And the tenet here is that with age, microvessels disappear. They disappear in diabetics, they disappear in hypertensives, and of course they disappear in a big way when an individual is atherosclerotic and are subjected to ischemic or infarcted damage to the heart or other organs. And it's that latter scenario that in fact has generated a tremendous amount of interest in trying to circumvent the problem of small vessels disappearing through the process of angiogenesis, and typically the so-called therapeutic angiogenesis. And this is an interesting aspect of translational medicine to consider because, in fact, the pathway from the early preclinical findings suggesting that you can actually deliver a growth factor that stimulates new blood vessels to the clinical trials, the decent-sized, well-designed clinical trials, was relatively quick, less than 15 years. And some of them I've just listed here, with Duncan Stewart's Northern trial being the best designed trial to date. I won't show the trial data. Instead, I'll simply summarize the data through this other metric that I've come up with, referred to as the excitement index, from fever pitch to total boredom. And this trajectory is like this. And that's because Duncan's trial came about here, and it was negative. Control patients that received placebo, these are patients with multi-vessel coronary disease, sort of no option, and bad angina, they got a little bit better, as did the patients who received the vascular endothelial growth factor. So then the question is, well, what do we do now? Do we just say, okay, this is not worth going after. Let's forget about the microvessels. That's what the biotech industry has said. It's no longer, the support would just dried up because this was not a winner. We could not simply grow new blood vessels and have it work. But it doesn't really address the reality that it's the microvessels in our tissues that are the business end of gas exchange, and that's really why we try and have all, that's where ultimately we want all of our vascular therapeutics to beneficially affect. There's no, you just can't think of one part of the plumbing without thinking where the action really takes place. And so we've stepped back and tried to, again, now move back from patients back into the mouse and ask the question, what in fact are the vulnerable steps in microvascular regeneration after ischemic injury? And did we really have the concepts right before we jumped into the translational undertakings? So John Michael Arpino, a PhD student in the lab, in collaboration with Chris Ellis in the medical biophysics department, has in fact developed the tools and expertise now to look very carefully at the microvascular level, in this case in the skeletal muscle, the hind limb of the mouse. The heart would be great, it's just beating too fast, so we go to a tissue that we think is going to give informative data nonetheless, and it's not beating. So here it is in skeletal muscle. So this is a processed image of the microvasculature showing, these capillaries beautifully aligned with each other as they're running beside and between skeletal myofiber bundles. They bifurcate, they bridge from one capillary to the other, and when you see them become a little more curvy, that's usually an indication that that's the venous venule part of the tree that these capillaries are draining into. The arterial side, generally harder to find because it's penetrating through orthogonally to the surface plane here. But if I roll the tape, you can appreciate that the order persists when you're thinking about it in terms of the flow. You're watching nice individual columns of single file red cells flowing fairly homogeneously throughout the surface of the skeletal muscle and draining into veins here. In contrast, this is the vasculature that has formed now 5 days after the femoral artery in the mouse has been ligated. The skeletal muscle has been infarcted. Mice do a great job regenerating. They kick right back a few days later and they're running away. But 5 days later, when we look at their microvasculature, clearly this looks like nothing like a capillary bed. Big fat vessels. It looks like an aneurysmal segment here. We normally don't think of like an aneurysm in a capillary, but this is what it looks like. And when you look at the flow here, it's clearly perturbed. Some area where there's actually it stops, doesn't go anywhere. It's very slow. None of this single file organization is taking place. Not a network that is going to be delivering nutrients, oxygenating the tissue with any effectiveness at all. Now, as I mentioned, mice are really good at regenerating. And so, in fact, if you wait long enough and take it out to, say, 4 weeks' time, a capillary network somewhat more reminiscent of what we started off with, in fact, does develop. And that's shown here. Now, it's still a bit raggedy looking. The edges are no longer smooth. It's kind of a little more tortuous. And when you look at the flow, there's a few interesting things you can point out, or that can be identified. If you go up here, this is a feeder artery. Now, instead of coming orthogonally, they are on the surface, and so you can actually see what they're like. And this is noteworthy because you can see it's trifurcating. 1, 2, 3. Trifurcations take place in medium-sized arteries. We certainly see them on the surface of the heart. But once you get down into the tissue at the business end, a trifurcation doesn't happen. You're in the world of bifurcating. It's fractals. You bifurcate, get smaller. Bifurcate, get smaller. It just keeps mirroring itself on a smaller scale. And yet that's not happening here. So it's structurally becoming weird. The flow also, hookups are very weird. Here's a venule down here. And it's going to mean collecting a number of, normally it would be collecting a lot of blood from a number of capillaries. In this case, it's a fairly limited number right there. And they're being fed from this branch of the arteriole right up here. Here's another venule. And what's it collecting from? Well, it's collecting from this thing right here, which is another branch of the artery that never ends up in a capillary tree. So this regulation is all wrong. I mean, there's no sense that oxygen is going to be delivered to the tissue in any effective way if it's doing crazy things like this. Furthermore, one of the fundamental functions of the capillary network, the microvascular network, is it has to gauge if you're in a hypoxic area, upstream needs to vasodilate, so flow increases, and vice versa. If that doesn't happen, flow into the tissue is almost irrelevant because it's not being regulated. It has to be matched with the need. So John Michaels set up this device where, in fact, he could regulate the level of oxygen right at the surface of the muscle and then see what happens to the flow into it. And here you can see under normal circumstances, red cells are flowing at 100 micrometers per second. You reduce the oxygen down to a level that the tissue normally would say, now I'm hypoxic, and look at the flow increase. In a regenerated vessel, and this is 4 weeks out, so this is the vessel that has lots of capillaries, and the scale has been doubled just for effect here, but it starts at a reasonably similar velocity, but the response to hypoxia is diminished and can't be sustained. So clearly abnormal. So we have put all of that together and felt that, well, at least there's probably several levels of abnormality, but certainly just the fact that blood vessels grow isn't good enough. There's clearly important vulnerabilities that need to be addressed, and we've proposed that one of the key ones is that what's lost is the ability to vasoregulate, which means what's lost, we think, is the ability to have vessels that have vascular smooth muscle cells that are wrapping around them and constricting and relaxing. So the question we asked was, are there in fact secreted factors, still sort of thinking therapeutically, something you might deliver, that promote the investment of new microvessels by mural cells, yielding a fortified and vasoreactive neovasculature? So sprouting's fine. The endothelial process works okay, but it has no function because we've proposed it has no proper wrapping of mural cells and smooth muscle cells. We've used screening processes in culture to identify what that might be. This is just mimicking a vascular network where we've added vascular smooth muscle cells and get them to wrap on the outside of endothelial tubes, identifying what might be important, genomic screening, and we came up with a growth factor. And this is the one here, fibroblast growth factor 9. It's actually a factor that's been enriched in the brain, a little bit in the kidney. Its function a little bit uncertain, but it was popping up in this screen and we pursued it accordingly. You can test to see whether a factor does in fact stimulate the growth of new blood vessels a number of ways. We did it again in the mouse just by putting a little patch of tissue beneath the skin. That patch is here. The skin's up here. We embed it with fibroblast growth factor 9, and it wasn't angiogenic. So it didn't stimulate the growth of blood vessels, which is interesting because all the clinical trials were with agents that stimulated lots of growth of blood vessels. This didn't. There have been clinical trials with FGF2, and you can see the brown staining for endothelial cells. It does stimulate blood vessel growth. We add FGF9. It's a big family member, but these are just two of the heavy hitters. That's a real heavy hitter. This is what we're proposing might be important. And it didn't change it. Still the same number of blood vessels. But clearly what happened was, although the number of blood vessels wasn't changing, their structure was. Effectively being converted from blood vessels with a single layer of endothelial cells in brown to a double layer with brown and red, the red being cells that express a form of actin. Here it is at another perspective looking at it. Red is, they've been double labeled for both endothelial cells and the presence or absence of that second layer of smooth muscle alpha actin expressing cells. They're bare channels with the angiogenic factor. They're no longer bare with the FGF9. You stack some confocal images and you begin to appreciate there is in fact circumferential wrapping of cells, and this means in fact these must be vascular smooth muscle cells. What's the consequence? The only one I'll highlight this morning is now we've in fact generated blood vessels that have microvessels that have vasoreactivity. This hasn't been done before in at a tissue level, but if you watch the movie, we'll add increasing doses of the alpha agonist phenylephrine and then the vasodilator sodium nitroprusside. This is a vein up here, and this is an artery here that you can keep your eye on. Add some phenylephrine, little squeeze, add a higher dose, big squeeze, and then a partial relaxation. So that level of functionality we felt was quite new. And in fact, the mice liked it too. So when we infarcted the leg, delivered this factor, they recovered so much better. Here's a mouse walking. He's a control mouse. You can look at his paws. You're not seeing this back paw on the bottom of the screen here. He's dragging it along because that's been the injured one. He's received vehicle. This guy has received the FGF9. He's touched down it there. They still favor it, but now it's not a completely dragging along. He's going to sit on it here for just a minute right there. And so we've at least had some functional effect simply by changing the structure of the microvessels. And the sort of paradigm that we're proposing, we think operates at the microvascular level, may be relevant at the large vessel level as well, is that certain parts of the vasculature can regenerate just fine. And one part of that is the endothelial cells. By fine, I don't mean they do it productively, but they can replicate and form tubes. And we know, of course, that all sorts of problems in the retina and other cases. But the sprouts form. The regeneration takes place amongst these cells. But there's no function. Simply having an endothelial channel there is unhelpful to the body. It won't last, and it doesn't have any controlling regulators on it. So what we're proposing is that, in fact, there are progenitor cells in the vicinity that will give rise to mesenchymal cells, perhaps not many, and perhaps highly susceptible to age-related complications. but that there are also, in their natural history is probably going to die as you age, or perhaps they'll senesce, and some suggested. But that there are factors that are fairly selective to these mesenchymal stem cells. FGF9 is one. Maybe there are more powerful mediators, but that in fact can suppress those roots and instead expand the pool of progenitors, and in the particular model we've used here, bring it all the way to a smooth muscle cell that has the appropriate receptors to be attracted to vascular smooth muscle or endothelial tubes, to stabilize them, have them last longer, deliver flow in a regulated fashion. So I'll just summarize by saying, first, unlike other tissues, the media of the artery wall is in fact ill-equipped, by and large, to call on replication-based repair mechanisms. And because of that, that's one reason why we feel they age poorly. And in large vessels, that's manifested by the accumulation of DNA damage, pushing the cell down a senescence pathway, essentially accumulating cells that are now going to seed and leading to large vessel problems. And we suspect a host of diseases. And in small vessels, this is manifested by essentially failed angiogenesis. The body wants to do it, but can't. And we propose that, in fact, there may well be cascades that can recruit the aging mesenchymal cell pool in an effort to optimize the vasculature over time. And I have mentioned some of the investigators that I've had the privilege of working with me. Here they are, either present or past members of the laboratory, as well as valued colleagues in our environment. And with that, I'll thank you for your attention.
Thank you very much, Jeff. That was an excellent presentation. Dr. Pasternak.
So that was really beautiful microscopy. When we see beading and irregular edges of blood vessels, actually, we think vasculitis. I was wondering if you could comment on inflammatory cells and infiltrates around those newly formed capillaries.
Yeah, it's complex. Angiogenesis in itself, in almost all models, doesn't take place at all in the absence of a certain amount of inflammation. And so clearly what needs to get sorted out is what's inflammation that's really part of the process, opening up the tissues, making sure the channel's there, making sure the endothelial cells can sprout into things, and opening up the pathways for mural cells to invest. And angiogenesis that is in fact, or inflammation that's in fact more pathological and going to lead to short term. So it gets to the field of immunology where monocyte subsets, et cetera, are going to be very important, but hasn't been looked at.
Any other questions for Jeff? Arthur Brown.
Hi, thanks, Jeff, for a wonderful talk. I'm wondering if, just to connect one or two dots, if you looked at the mouse mutant that has the collagen that's resistant to degradation, I'm wondering what kind of cardiac symptoms it may have, and have you tried the FGF9 to see, sort of pull it all together? Does any of that?
Yeah, those are nice thoughts, Arthur. We have not. I've been curious to see what their vasculature looks like. We've looked at their heart a little bit, but the reality is we only want to breed so many mice at once before blowing the bank, so I haven't done that.
Any other questions for Jeff? If not, David Holdsworth.
Hi, thanks. That was a great talk, Jeff. I'm interested in vessels and in bones, and another thing that I always think of in aging vessels is that they start to calcify and of course accumulate quite a lot of material that's a lot like bones. So is that another factor in this aging process that indicates some lack of ability to repair, or it's just something that I find intriguing? Oh,
very much so, David, at a number of levels. I haven't talked about cellular calcification as an aging phenomenon, but certainly it is. Defects in calcification. In fact, some of the earliest models of accelerated aging globally are molecules that in fact perturb the mineralization and calcification response, phosphate homeostasis, for example. But I think even more broadly, as we are trying to think more and more what it is that in fact rejuvenates and invigorates the mesenchymal parts of our bodies, of our tissues, the biomechanical angle, I think, must be very important. And I think there again, bone and the vasculature may have some very interesting linkages in terms of what one does to prevent osteoporosis and what one might do to also prevent thinning out of blood vessels. And it's very biomechanical. Maybe it will all come down to exercise and knowing how exercise is going to impact this, for example.
Dr. Paraga.
Thanks, Jeff. If Dr. Holzer is going to talk about the bones, then I have to talk about the lungs. As you know, we've been looking at healthy aging adults and their pulmonary airways. And what we've seen now is that the airways become either pruned or dysfunctional. And of course, that airway tree is matched by the vascular system. Do you have any insights? There's smooth muscle cells in both of those that fractal network.
Obviously that there are, I don't think I can give you really any novel insights, Grace. Without question, it's fascinating really how much, from a structural standpoint, what's happening in airways in some senses recapitulates what's happening in the vasculature. But I think it gets confusing because from the vascular standpoint and oxygenation standpoint, at least in terms of the vessels, everything's backwards. In terms of vasomotor control, hypoxia does something different in terms of the end result. I think the conduction of alveoli change everything, the presence of alveoli. But the fundamental notions of, and likewise, the problem in the lung, most people think, for things like pulmonary hypertension, asthma, is hyperreactive airways. And I'm arguing in the periphery, it's exactly, in periphery of vasculature, it's exactly the opposite. Hyperactive vasculature, too much smooth muscle cell. In the periphery, I think it's the opposite. So I think those are the sort of paradigms that I think need to be thought through.
Well, Jeff, thank you very, very much. Not only have you given us some new insights into angiogenesis and post-ischemia, and we look forward to hearing more about that in the future. Thank you very much. I would like